So, as we said, it's an imaging modality that utilizes the natural fluorophores of the RPE, which is lipofuscin, and it therefore provides functional images of the retinal pigment epithelium. What is lipofuscin? It's the undegradable fraction of the byproducts of the visual cycle. As you know, the RPE recycles the discs of the photoreceptors, and anything that is non-degradable actually stays in the lysosomes of the RPE towards the base of the RPE. And so the lipofuscin actually is a term that we use to designate the byproducts inside the RPE and not outside. And this lipofuscin is actually autofluorescent. So if you have a lot of lipofuscin inside the RPE, this compromises the function of the retinal pigment epithelium, and therefore the map, the autofluorescence map, indicates where the RPE is healthy and where it is not. How do we image autofluorescence? We can't really use a conventional camera because the light that is emitted by the retinal pigment epithelium lipofuscin is actually very low, and the camera is non-focal, so we'll have a lot of noise. We won't be able to interpret what's coming out from the RPE itself. So we have to use other techniques such as the confocal scanning laser ophthalmoscope or a modified camera. With the confocal scanning laser ophthalmoscope, we generally use a blue light. This is a technology, for instance, available on the Heidelberg. The light is shined on the eye, on the fundus, thank you, and it basically goes through a pinpoint to the retinal pigment epithelium, and then the light that is reflected back comes through a pinhole to a detector, and only the light coming from the retinal pigment epithelium is able to go through the pinhole. So we actually get pretty much an image of only the retinal pigment epithelium and not any fluorescence that's coming from other places. So there's no interference from the lens, but of course this is a technique that requires averaging and is quite expensive. With a modified fundus camera, the technique is not so expensive. We use green light to excite the lipofuscin inside the RPE, and this green light bypasses the lens, which is yellow, and we use this. Therefore, we click a button. We focus on the fundus. We click a button, and we have a single shot and an entire cone of light that captures a single image. But in this case, of course, we don't have the advantage of having light coming only from the retinal pigment epithelium, but also from elsewhere. So it is subject to pseudofluorescence from the lens in any area in the eye that is quite bright. But the advantage of it is that we don't have absorption, because it's a green light. It's not the green light is not absorbed by the macular pigment epithelium. By the macular pigment, which is yellow, the xanthophyll, and therefore we can assess the retinal pigment epithelium under the fovea much better. So how does a fundus autofluorescence image look? Well, you recognize it by having a dark optic nerve and a dark vessels, and then the central area is also dark, because for three reasons. One of the reasons is that there is less lipofuscin in the retinal pigment epithelium under the fovea than the rest of the fundus, and also because as you know, the fovea, the RPE under the fovea is very highly packed with the melanin, and the melanin blocks the light, so that's one reason, and also because you have absorption of by the luteal pigment. So this central area of the macula is usually dark, and then around 10 degrees around that, that's the highest intensity of autofluorescence, and then you have a homogeneous autofluorescence over the rest of the fundus and the posterior pole. And this is the normal autofluorescence of an eye, and it reflects the normal photoreceptor outer segment turnover and the retinoid cycle. We can recognize by looking at images which one is done with a confocal scanning laser ophthalmoscope and which one is done with a modified green camera. The one with the scanning laser ophthalmoscope tends to have very dark contrast of the vessels, very dark optic nerve head, and a dark center, while the ones at the bottom here, you will see that the central part is is not as dark because there's no absorption by the xanthophyll. We can also do fundus autofluorescence with a light that is near the infrared range, and in this case we're no longer exciting the lipofuscin, but we're exciting the melanin inside the retinal pigment epithelium. So in this case, what we'll have is completely the opposite. We'll have actually a very bright fovea because the RPE under the fovea is highly packed with melanin. And so here are the three images that you can recognize now. The one on the left here is done with a blue light, very high contrast and dark center. The one in the center is done with a green light, and it doesn't have a very dark center. And the one at the right is that uses the infrared light. Now, You have to remember that fundus autofluorescence is an imaging technique, so it will only provide you a relative analysis of autofluorescence intensities and not a quantitative analysis of how much lipofuscin is in the eye. And you cannot compare the intensities of the autofluorescence from one exam to another because the situation between a test and another is different. And you also have to remember, because it's an imaging technique, therefore it will depend on the clarity of the media. So if you have blood or any or lens nuclear sclerosis or anything that's in the media, that's going to interfere with the signal detection. But this is what you have to remember, that as long as the retinal pigment epithelium and the photoreceptors are in contact and the relationship is intact, then the autofluorescence intensity is going to parallel the amount and the distribution of lipofuscin in the RPE. And there will be no accumulation of autofluorescence and lipofuscin unless the phagocytosis of the RPE is compromised. But if the photoreceptors and the RPE are separated, then you don't have a normal phagocytosis. Then fluorophores are going to accumulate on the anterior surface of the RPE, between the RPE and the neurosensory retina, and those fluorophores are highly autofluorescent. So when do you have brighter autofluorescence? Every time that you have an RPE dysfunction, when you have an intrinsic failure of the lipofuscin clearance, or if you have just an abnormal metabolic load, such as we have in Stargardt's disease or in some pattern dystrophies, or if you have a lack of absorbing material, in this case like juxtafoveal telangiectasia type 2, you don't have the xanthophyll, therefore the signal is brighter. Or if you have, as I said, material, autofluorescent material between the RPE and the photoreceptors, such as in Best's disease or chronic CSR, or under the RPE, such as in big drusen. And when do you have hypoautofluorescence or loss of the autofluorescent signal? Is that when you have a reduction of the photoreceptors because there's not enough retinoid for recycling, or if you have an increased lipofuscin clearance by the RPE, such in some outer retinal degenerations, or if you don't have, excuse me, or if you don't have RPE cells, if those are lost or tired, such as Stargardt's or GA atrophy in AMD, or if you have loss or a mixture of lipofuscin and lots of melanin, this is going to decrease the signal itself, or if you have a blockage. So let's look at some cases. Now, what you need to remember is that this is an imaging modality that provides additional information to other imaging modalities and helps you, therefore, measure the disease stage and activity. So, what I find is very, very useful is in hereditary retinal dystrophies. For instance, this is a patient with a retinitis pigmentosa, and what you will notice here is that there's a ring of hyperautofluorescence around the fovea. And this is really invisible on clinical examination, but this has a lot of importance. This is the same patient with the wide field imaging. You can notice the ring of hyperautofluorescence in the center, and then the disturbances of the autofluorescence due to blockage by melanin, but also by the pigment, but also by some retinal pigment epithelial atrophy. But this ring actually maps the sensitivity of the retina. So if you do a microperimetry or if you do a visual field, you'll find that inside the ring is the functional area, and outside the ring the patient basically has no vision or very, very reduced sensitivity. And this correlates also very nicely on the OCT. Notice how on the OCT you have preservation of the outer retina, the ellipsoid zone, and the external limiting membrane is still present under the fovea. So all this together, non-invasively, you can have an idea of how much the patient is dysfunctional, how much the vision is dysfunctional. Sometimes the perifoveal ring appears even before clinical changes are obvious, such as in this case of retinitis pigmentosa. So anyway, here's another case of retinitis pigmentosa. The ring here is a little bit bigger and larger, and the central area is slightly larger. You can see that there's also preservation of the outer retina, and therefore the patient does have a tunnel field, but the tunnel, and you can kind of estimate, how much field is remaining by looking at the ring. And if you do if you follow the patient non-invasively with autofluorescence, you'll notice how fast the patient is progressing, because this ring will tend to constrict over time. Here's a patient with Usher syndrome who didn't have a lot of problems with the central vision because the ring is actually quite large. Notice that you don't really see it on the color photos, and you notice that the OCT showed a much larger preservation of the photoreceptors. In cone dystrophy, the opposite thing happens. Here's a patient. You notice that this is not a fundus autofluorescence, it's a fluorescein angiogram. You can recognize that the vessels are actually bright and the optic nerve is bright, and there's a window defect in the center. this is the same patient with autofluorescence. Notice how immediately you can tell how much dysfunction there is. Now, in cone dystrophies, the opposite thing happens, is the area inside the ring is the area of lost sensitivity or decreased sensitivity, even if it looks normal on clinical examination. And so in this area, in this case, on the right on top, you can notice that the ring is large. Everything inside the ring is hyposensitive. Patients don't see very well, and in this very, very center, there's a dark area of loss of autofluorescence that corresponds to the geographic atrophy with only a little tiny island of fovea remaining. So you can tell that the patient is very, very much handicapped. And notice on the OCT how much there is loss of photoreceptor outer segments. Here's another example, basically showing the same thing with a huge loss of outer photoreceptors. This is another case of a cone dystrophy. Notice how on the fluorescein angiogram at the bottom, you don't really see how clearly where is the geographic atrophy in this area, but in the autofluorescence on top, and you know that this is a green autofluorescence, right? Because the optic nerve head is slightly bright, it's not so dark. But notice that you have the very, very dark area corresponding to the total atrophy of the retinal pigment epithelium and RP and the photoreceptors, but then again you have a ring that also shows that it's not just the atrophic area, but it's this whole area within the ring that is quite abnormal. Here's the second eye of that same patient. In rod cone dystrophy, same thing happens. You have, again, major losses of the retinal pigment epithelium and photoreceptors in the center. And so on autofluorescence, you can immediately tell how much damage there is and the dysfunction of the patient in a very non-invasive manner. I'm going to go over it. So basically, what's the value in retinal dystrophies? Well, it indicates disease sometimes in the absence of visible changes, as we showed you one case. It correlates with function. It identifies the carriers. And very importantly, now that we are in the era of gene therapy, autofluorescence is going to identify the areas where there's still viable retina. And therefore, if you're going to inject vectors with virus vectors with the normal genes to protect and to promote to restore the retinal function, then it's important to do that in areas where there's viability. So this will tell you where there are still areas of viable retina. Now, autofluorescence is also very helpful in macular dystrophies. So, for instance, in Stargardt disease, you know that there's
One minute to go, please.
Okay, I'll go very fast. In Stargardt disease, you have an RPE that's loaded with lipofuscin, and therefore the intensity of the autofluorescence of the fundus is quite elevated, but the flecks tend to be very, very hyper autofluorescent because they're loaded here again. We can see at the bottom the flecks very hyperfluorescent. Here's another case of Stargardt disease. On the fluorescein angiogram, you have a dark choroid. On the fundus autofluorescence, the whole background is quite bright, and the flecks are very bright, and the areas where the RPE is atrophic and dead, those are dark areas. Stargardt disease can be mapped, the progression can be mapped with autofluorescence. You can see here, for instance, we have a case in which the geographic atrophy extended, and you can easily see this on autofluorescence. So here's another case of mine in which there was actually a huge ring showing the decreased autofluorescence in the center corresponding to the loss of sensitivity, and then the hyper autofluorescent flecks. Pattern dystrophies can also be seen easily on autofluorescence. You have these intervening normal areas between the very bright areas. Here's another case. And Best disease. Best disease is a case where you have accumulation of fluid between the retinal pigment epithelium and the RPE, between the RPE and the photoreceptors, I'm sorry, and so that fluid tends to be, blocks the fluorescence, as you can see on the fluorescein angiogram, but anything that blocks the fluorescence is very hyper-autofluorescent in general. So you can see how bright that area is on autofluorescence, and you can see at the OCT where the fluid has accumulated. Here's another case. Notice that the top right part is the autofluorescent area, very, very bright, and the bottom part are the fluorescein. Vitelliform exudations can happen also with specific drusen. This is an autosomal recessive bestrophinopathy. Again, autofluorescence clearly shows the areas that are laden with lipofuscin. Central serous chorioretinopathy, very similarly to BEST, will show you areas of hyperautofluorescence, and it can also show you the areas where the RPE has died. So I'm not going to go through over this, just to show you that it's an imaging technique that that can help a lot in understanding a little bit more about the disease, and it maps the function of the RPE, so it'll give you an idea about the health of the RPE, and it's very important as a marker in trials to see whether if you're for instance, applying as example, like you're testing a medication to see if it decreases the progression, and since you have a marker for progression, this is a very useful technique. Thank you very much.
My first talk today is about the RVO management, especially the macular edema, and compare the intravitreal pharmacotherapy and versus laser. And the question here, does it really, laser still have a role in the management of macular edema secondary RVO or not? So going to the incidence of RVO, so I think all of you know that's the second most common vascular disease affecting the retina after diabetic retinopathy, and for sure the most common cause of visual loss is macular edema. Regarding the treatment modality we have, as I told you, we have laser treatment, which should be now the previous standard of care. Now we have the intravitreal pharmacologic therapy, and either anti-VEGF or steroid, which should be the standard of care right now, and we are going through why. We know about the surgical intervention for RVO, but I think now the role of surgery has been limited significantly nowadays. So going to this main point from my presentation today, the intravitreal pharmacotherapy actually should be the standard of care when dealing with macular edema secondary RVO, and the role of laser actually has been limited. And we are going to go find some evidence for this statement by going through the pathogenesis of macular edema and the RVO, the natural course of the disease, the mechanism of action, which as a rule also, and some evidence-based efficacy for both treatment modality. Starting with the pathogenesis of macular edema, we all know about that, just to refresh our memory, that it's some AV compression at the AV changes leads to a lot of events. So actually it ends with retinal ischemia and overexpression of the vascular endothelial growth factor, which lead to the macular edema. And also we cannot deny the role of inflammatory mediators. That has been evidence that there is a strong evidence supporting the inflammation play a role in the pathogenesis of the macular edema and the RVO. So the main issue here, or the main factor here, either overexpression of the vascular endothelial growth factor and some inflammatory mediator that have a role in the pathogenesis of macular edema. What about the natural history or the behavior of this disease? We all know that the RVO, it's different or behave different way compared to the diabetic retinopathy, for example, or AMD. So as we have many patients that can resolve spontaneously without any treatment. So this is a very important point we should put in our mind while dealing or treating those patients. That is some percentage of patients that resolve spontaneously without any treatment, either in CRVO or PRVO. What about the mechanism of action? Talking about first is about the laser. Actually, laser main mechanism of action is destruction of the photoreceptors with high oxygen consumption due to rich in mitochondria, and this actually leads to decreased oxygen consumption in the outer retina, and this followed by cascades of events, finally lead to less flow of fluid into retina and decrease macular edema. So this is the main how the laser works, by destruction of the photoreceptor, decreased oxygen consumption. What about the steroid? We all know that there's a lot of trial that showed that the steroids, dexamethasone specifically, blocked secretion of many inflammatory mediators that have been involved in the pathogenesis of the macular edema and RVO. Also, the anti-VEGF therapy. We have strong evidence from trial that, for this study, for example, it showed that the level of the vitreous concentration of the vascular endothelial growth factor is correlated directly to the severity of macular edema. And we all know another trial that proved the role of VEGF overexpression in the treatment of macular edema second to the RVO. What about some evidence-based efficacy regarding this issue? We start with the laser treatment trial. We are aware about the old trial about the branch vein occlusion and central vein occlusion. It was 1984 and 1990. It's very old, but still those who are still using laser are following the guidelines from this trial. The intravitreal steroid, we have the most common one is Ozurdex or Geneva trial, and we have a lot of intravitreal anti-VEGF trial for both BRVO and CRVO, and we have now for both most commonly now used the ranibizumab and the aflibercept, was approved by FDA. Just go through quickly about the results of the branch vein occlusion if you want good laser for this patient. So the first point or the first question to be answered was the grid laser treatment does help or improve the visual acuity in macular edema secondary to branch retinal vein occlusion. With those criteria, more than 3 months, because it is logic, we have to wait at least 3 months for the retinal hemorrhage to resolve, so the laser will be more effective. And also should be non-ischemic, and the visual acuity should be 20/40 or more. This is the indication of macular grid based on the branch vein occlusion laser study. And the answer was yes. So yes, laser can improve vision in those patients with this criteria. What about argon laser can prevent the development of neovascularization? The answer was no. And finally, does peripheral scatter laser decrease the incidence of vitreous hemorrhage? The answer was yes. What about the central vein occlusion study? This is the same laser treatment study for the macular edema secondary to central retinal vein occlusion. And the same question was offered there, but whether the grid laser can help or not, and the answer was no. There is no anatomical, there is no visual improvement at all. The second point is whether refractive laser can prevent the new vessels, and the answer was no. So just to show you the result of this central vein occlusion study, I want to show you. You can see here there is no difference in visual gain for those who receive treatment in form of macular grid versus no treatment. There was some anatomical actually improvement, but not reflected in the visual acuity. So laser was not recommended to treat macular edema secondary to RVO. What about the intravitreal steroid? We have this code trial, which is triamcinolone, which the use has been limited nowadays because it was replaced by Ozurdex or dexamethasone implants. It shows also a great improvement in visual acuity compared to the sham group, and we can see at the end of the trial there's some drop of the visual gain. This is because of the cataract formation in those patients. Anti-VEGF trial, there are many. But the most common is Bravo for ranibizumab, Brighter study, ranibizumab versus laser, and Vibrant study is aflibercept versus laser. And also we have some, the main trial was Cruise in ranibizumab, and the Copernicus and the Galileo and aflibercept. Going quickly through the Bravo, for example, you can see here that ranibizumab with 2 doses, the visual gain at 6 months was significant difference between both the sham group and the treated patient with ranibizumab. And if you, after the 6 months, if you can see here, those patients start to receive PRN ranibizumab. And you can find that when they start to get ranibizumab, they start to have visual gain. The same change exactly happened in Cruise, which is ranibizumab in central retinal vein occlusion. Also in Copernicus for aflibercept, the same finding. The gain was significant difference between those who had received anti-VEGF compared to sham group. Galileo the same even. So what about the VEGF anti-vascular arterial growth factor versus laser? We was needing a high head-to-head trial to prove that. So the answer actually came from Brighter study, which compare or studied the head-to-head between ranibizumab, either monotherapy or with adjuvant laser against the laser. And it's very clear here that the improvement in visual gain actually was significant in the ranibizumab and ranibizumab adjuvant laser compared to the laser monotherapy. So this is a good proof that the anti-VEGF actually do much better than laser. What about Vibrant trial? It's the same one for aflibercept. You can see also at the 6 month how significant difference between the gain for those who are receiving anti-VEGF or aflibercept versus the laser, and also the same finding, those patients in the sham arm, when you start to receive injection of aflibercept, they start to gain vision. So to conclude the laser limitation actually in management, for the central retinal vein occlusion, according to the central retinal occlusion study, there is no rule for laser in management of macular edema. What about branch retinal occlusion? As I told you, yes, there is some improvement, but for those patients with delayed treatment more than 3 months, non-ischemic macula and visual acuity 20/40 or worse. And for sure, the last thing is the chronic complication from the laser. We are distracting the photoreceptor for a disease that is behave differently, and it could be there can be spontaneous resolution. So I think it's no need to shoot the target through our head. And the main point I want to comment here actually is the delayed treatment. So if you want to do laser, you have to wait at least 3 months, as I told before, for the lateral hemorrhage to resolve. So does this delayed treatment have impact on the final visual outcome? Or in other words, what is the rationale for early treatment in RVO? The answer actually came from the Bravo. I saw you this slide before, but in this time I want to show you different points, which is the the overall or the final visual gain. If you look at those patients in the sham arm who start to receive treatments, PRN after 6 months, they improve vision. But if you look, they never. Also, just at the same time, the same finding was seen in Cruz trial with central retinal vein occlusion, that those patients who receive the treatment early from month 1, the final visual gain at the end of the trial was different between those who delayed for receive the treatment for 6 months. So the idea here that early treatment is really matter in the management of macular edema secondary to RVO. Also, these changes was also the same in Vibrant trial. When you, I hope that it worked to show you again. Also, those patients who start to receive the aflibercept after 6 months, they never catch up or have the same visual gain at the end of the trial. The other point is, what about ischemic RVO? So, because we all know that if you have ischemic RVO with macular edema, we thought that the laser might work better. When I said ischemic RVO, I do not mean that there is new vessels yet. So it's ischemic, but not yet new vessel developed. Still, we have macular edema in ischemic type. And the answer actually came from Brighter study. Brighter study, they have subgroup analysis of patients who have ischemia versus national ischemia. You know, the Brighter was comparing the ranibizumab, either monotherapy or with adjuvant laser, in ischemic and non-ischemic RVO, compared to the laser also in ischemic and non-ischemic. So when they make subgroup analysis and to compare the results in ischemic RVO, they found that the either ranibizumab monotherapy or with adjuvant laser is doing much more better than laser alone. So even in ischemic cases, still the anti-VEGF have priority or upper hand compared to the laser. The same finding also was in Vibrant trial for aflibercept. You have the subgroup analysis of the ischemic type, and they found also the same, that aflibercept is doing much more better over laser, even if you have ischemic PRVO. So,
Okay, Dr. Ahmed, 1 minute, please.
So I think, sorry?
1 minute, please.
Well, I've done already. So the conclusion actually, if you give me some time just to show the Brighter, just one. So I want to show you best the Brighter about the ischemic, because we didn't discuss this point. What about if you have ischemic RVO without development yet of the new vessels? And also, okay, this is the laser imitation. And this is what I want to show you, that the those who receive treatment early never catch up with the final visual gain. Those who tried. Also in Exudates is the same. Patients who receive treatment early behave differently. So that's what I want to show you here. This is the forearm of ranibizumab monotherapy with adjuvant laser in ischemic and non-ischemic. The upper 4 lines. The lower one is the laser monotherapy in ischemic and non-ischemic. So again, we don't repeat ourselves, still doing so. In conclusion, actually, intravitreal pharmacotherapy, either steroid or anti-VEGF, should be the standard of care nowadays in management of macular edema and RVO. And the role of laser should be limited only for those cases who develop new vessels. As you know, anti-VEGF does not treat ischemia. We are just treating the consequences of ischemia, which is overexpression of VEGF. And thank you for your attention.
Thank you, Dr. Ahmed.
Bismillah ar-Rahman ar-Rahim. Good morning. Thank you, Chairperson, Professor Ahmed Abul Asrar, and Dr. Benton. I would like to congratulate the Organization Committee and the Scientific Program Committee of the Red Sea for their third meeting. And I would like a special thank for Dr. Abdullah Al-Qahtani for holding this important subspecialty day. I hope the chairperson can give me more time than spending more time in discussion. In healthy eye, the rodent cones on the retina convert light into electrochemical impulses that are sent through the optic nerve and into the brain, where they decoded into images. If the retina no longer function correctly due to outer retinal degeneration, disorders such as retinitis pigmentosa, the optic nerve can be given information from the artificial sources. Retinitis pigmentosa is a group of inherited retinal degeneration leading to blindness due to photoreceptor loss. The optic nerve and the lateral geniculate nucleus and visual cortex provide alternative stimulation targets. There is no therapy by which the course of most of these retinal disorder can be modified. Several different approaches to restore sight to those blind patients from retinal degeneration, mainly due to retinitis pigmentosa, currently under investigation or start in use. And some of them are clinical trial stage or being investigated in the laboratory, like gene replacement therapy or modulation of ocular autoimmune responses, transplantation of stem cells, photoreceptor cells, or bioengineered sheet of retinal tissue, intraocular administration of neurotrophic, anti-angiogenic, and antioxidant agents. Retinal prosthesis system stimulate the residual inner retina, mainly ganglion and possibly bipolar cells, taking the place of the degenerative photoreceptor cells, directly with signal transmitted by the normal visual pathway to the visual cortex. The signal then can be processed by the brain to generate visual perception. Visual prosthesis available now for therapy is the epiretinal, either epiretinal or subretinal or suprachoroidal. In KKH, two different approaches, in King Khalid Eye Specialist Hospital, two different approaches to restore sight for retinitis pigmentosa was achieved. Dr. Aboud and his colleague started the ocular subretinal injection of adeno-associated virus gene vector to 3 Saudi patients with retinitis pigmentosa due to MERTIC mutation, and the result of phase 1 trial showed no major side effect. Visual acuity improved, but unfortunately lost in 2 years in 2 out of 3 patients. The second approach is the retinal prosthesis system, ARGUS-2. Retinal prosthesis ARGUS-2 is portable, consists of camera on a pair of glasses, capture images, and send information to the video processing unit, convert the image to an electronic signal, and send to the transmit on the glasses. The implanted receive wirelessly, receives the data and sends the signal through a small cable to the 60 individual electrode arranged in rectangular epiretinal stimulus array, causing it to emit electrical pulses. The pulses stimulate the cells, the vital cells in the retina as ganglion and bipolar cells, and the responses travel through the optic nerve to the brain to perceive light. ARGUS-2 is 2 components, internal and external. The internal component is ARGUS implant, where the electrical stimulation device that is implanted in the client eye, and the radio frequencies coil as well, and case. And a case are stabilized around the eye pole using the scleral band, and the suture and thin film of electrode array is stacked into the retina surface at the macula. External part is the ARGUS glasses, where it are specially fitted with the video camera and the radio frequency coil and associated electronic circuitry, and the glasses transmit electrical stimulation data along with the power wirelessly to the implant. Then the video processing unit, which is a battery powered device that processes the video signal and transform it into electrical stimulation data, and the electrical stimulation data and are sent to the ARGUS-2 glasses. The client learn to interpret this light information as a meaningful images. The system customized based on a measurement that taken by the clinician, create customized setting to and load them to the client VBU. The system setting will be customized, and the patient received adequate training before take it home. They attend fitting session generally around 10 hours in the first 6 weeks post-surgery. The procedure, usually the surgeon have refresh surgery training, which needs at least once a year. To avoid any issue like damaging the electrode during surgery, you have to master how to handle the coil and the electrode with the coated forceps And this is very important not to destroy the electrodes. Update the surgeon for any new or modified steps. The implanted in procedure conducted under the general anesthesia, electronic stimulator and antenna of the implant were sutured into the sclera, bare sclera with encircling band. Pars plana vitrectomy and electrode array and cable were introduced in the eye through the sclerotomy. Rehabilitation session is a very important session, facilitate part of the Argus 2, and it is without it you cannot really succeed in providing enough support for the patient and improve his performance. To perform in regular interval in the first month after surgery. Patient satisfaction depends on his ability to use the system correctly to find benefits in daily living tasks. The therapists need to find and define small goals together with the patient. And this is very helpful because these small goals help to keep the patient motivated and to work since he can see progress. The goals of the rehabilitation is to make the patient independent, improve performance of real-world function vision task. Example, he can differentiate items on the table with the clothes or with a bare table. He can, the sidewalk tracking where he can often, the subject turned away from the test course. Work direction discrimination. The subject were tested on a number of items and they correctly identify the direction of his tester walking in front of him. The aim of this is to improve their daily living task, where they help them to detect flashes, flashlight in dark room, detect light on the ceiling of the testing room, navigate in corridor using ceiling light at reference, detecting doors and window, detecting if the door is open or closed, and detecting obstacles in their way, train the visual memory of the patient on a specific shape. I just want to remind you, these patients were seeing before, at least in the average in our patient, the patient blind from 3 to 10 years before he received the implant. So their memory still remember things. You just need to refresh their memory. Outside, they can differentiate grass from footpath, scanning trees and general shapes in the buildings. In clinic system training, patient will be trained in a few basic skills that are required for full benefit of the patient. These skills are eye movement and percept location awareness by using the scanning tube. I don't see this working. Maybe you can see this, the scanning tube here, help the patient to orient the eye movement with the head movement. Eye position and the radio frequency link awareness, head scanning, home use training, inverse mood and program setting. These training sessions occur in the clinic with the site visit. Functional low vision observer rated assessment instrument is a multi-component instrument that consists in part of observer rated assessment of 35 tasks completed with the device on versus off. The 4-point scale is using to score completed tasks ranging from easy, score 1, to impossible, score 4. The tasks are evaluated individually and organized into 4 discrete domains, including visual orientation, visual mobility, daily life, interaction with the others. Supportive factor to address patient optimization outcome for Argus 2 is patient selection. Age, his motivation, his interest is very important. His commitment to attend the rehab session, to practice at home, it's very important really for the outcome. Family support, very important. The family should be, one of the family should be available during each rehab session. And expectation, you should talk to the patient. Their expectation is much higher than what the implant can give them. Proper screening, the physician play a major role here. Trust me, the patient, they don't trust the therapist as much as they trust their physician. So you have to know the implant and the implant structure and the information, speak to patient, explain to him. This will help in patient counseling, patient education, managing his expectation and compliance with the training. Successful surgery, this is very important, and we will see further, and the rehabilitation follow-up. Patient need to understand the following point before surgery: how the Argus system to work, what can we get using the Argus system, the concept of rehabilitation, patient and care providers involved in. The rehab implies several visits for the surgery. He should be willing to attend. The most of our patients, if not all, from outside Riyadh. King Khalid Eye Specialist Hospital is the center with the highest volume of Argus 2 procedure performed in the Middle East and the second in the world. Why Argus 2? Because the Argus 2 implant is FDA approved treatment for inherited retinal degeneration that restore simple vision. The aim is to provide our patient with safe, practical, and portable, stable, long-term retinal stimulation. Long-term, and I mean it. To improve the visual function of patient and help them in their retinitis pigmentosa. We presented here the result of King Khalid Eye Specialist Hospital and compared to the result observed in the investigational clinical trial, in the investigational clinical study international. First case implanted in 2nd of February 2013, and by December 19 this year, the patient number 11 has been implanted. The mean implant duration from 2.3 years, from 1 month to 3.9 years. None of our patients experienced serious adverse event. None of our patients experienced explantation of his implant. 80% have received visual function improvement. 70 have experienced a large visual function improvement, counting finger. 60 patients demonstrate functional benefit by independent therapist evaluation. This is our patient, all of them retinitis pigmentosa, 3 of our patients Bardet-Biedl syndrome with Conrod dystrophy, and all of them, their implant up to date active. The procedure has 2 parts: extraocular placement, where we implant the coil under the rectus muscle, and you can appreciate, I don't know if this is working or not. You can appreciate the coated end forceps, that how to hold the implant to avoid destroying the electrodes. And then we insert the implant under the muscle. We suture to the scleral buckle, and to suture the implant based on a specific measurement done by the second site group, based on the axial length of each patient. Then the surgeon will do either barsiplanal insectomy if the patient, or phaco without IOL implantation if we are planning to do that. Barsplanar vitrectomy, make sure that the vitreous detach and there is no epiretinal membrane. Then the sclerotomy, based on the measurement of the axial length, we insert the electrode array through the sclerotomy parallel to the cornea, and this is the challenges part of it, where we tack the array to the retina. It's very important to tack the array in the center of the macula, center to the fovea. Part of the array edge should be at the margin of the disc. And then you cover the coil with a graft material, and then closed with the conjunctiva. This is the right location of this is first day post-op for my patient. The right location, center in the macula, center fovea here should be. The edge of the array should be at the temporal edge of the optic nerve. This is very important location to succeed. This is the summary of our patient with the average age of 41, 26 to 55. 4 left eye implanted, 7 right, implanted and axial length is the average 24. We did 3 lens aspiration or phaco, and we left the patient aphakic, and 7 patients were already pseudophakic. We did for them posterior capsulectomy if needed. You should do posterior capsulectomy if it's not there. The sclerotomy width 5.2, and 45% of the patient had posterior vitreous detachment induced during surgery and epiretinal membrane peeling. The material we used to cover the extraocular portion of the device is the tutu patch, and all of the patient. The duration of the surgery from 2 to 4 hours. Adverse event, we have conjunctival erosion in one patient, which sorted by removal of the nylon suture, replaced with Merceline. The second adverse event is the patient not recognized during surgery that he has buccal with retinal fold, and you see here very important things. In spite of that, in spite of the foveal fold, the patient can see, can find doors, can follow ceiling light, can notice people pass in front of him in spite of retinal detachment and his dystrophy as well. And this is because the area, if you notice that, the area here is less than 1,000 micrometer from the retina surface. The second one is vitreous hemorrhage, which resolved spontaneously. The fourth one is my patient with high IOP, and I recognize that the high IOP could be because I noticed that I tight a bit the band, and we solve it by releasing the band. I just want to show you this slide is very important. Compare our patient to the international patient. We don't have any choroidal detachment or hemorrhage. 0 compared to 1.3 internationally. We don't have any endophthalmitis case compared to 2.8% internationally. No hypotony. Internationally, 5.7 patients have hypotony. Retinal detachment 0, while internationally 6.3% of the patients have retinal detachment. No retinal breaks, while internationally 3.3 patients. Our surgical outcome is very impressive.
Good morning. I would like first to thank the organizing committee and especially Dr. Abdullah Qahtan for his generous invitation and allowing me to share in this prestigious meeting. My talk is about ILM surgery in myopic traction maculopathy. The spectrum of myopic traction maculopathy consists of myopic macular hole without retinal detachment, myopic macular retinoschisis, and myopic macular hole retinal detachment. And in my opinion, this is a continuous spectrum. And let us look at this patient with myopic foveoschisis and epimacular membrane in February 2011. Soon he developed a macular hole, and then the macular hole led to myopic macular hole retinal detachment. So every stage leads to the next stage. What are the forces acting on the posterior pole of a myopic patient and lead to the myopic traction maculopathy? The posterior hyaloid undergoes partial posterior vitreous detachment and is still attached strongly to multiple areas of the retina, including the fovea. The ILM is altered, and it seems that the ILM becomes stiffer. The retinal vessels are potent or rigid, as described previously in the Japanese literature, and there is progression of the posterior staphyloma. So the first three factors lead to traction on the soft part of the retina toward the central part of the vitreous, and the last factor lead to traction on the retina in the opposite direction or background. So the hypothetical mechanism of myopic foveoschisis is that there are traction over the rigid. There is traction over the rigid part of the retina toward the center part of the vitreous cavity, and at the same time, the flexible part of the retina cannot manage this traction and remain attached to the sclera, which by its progression leads to the foveoschisis. The current techniques for management of myopic foveoschisis and myopic macular hole retinal detachment are vitrectomy and peeling of the posterior hyaloid only, vitrectomy, peeling of the posterior hyaloid and ILM peeling, and vitrectomy, posterior hyaloid peeling, and inverted ILM flap as introduced by Jerzy Nabarowski, and macular buckling. And in my opinion, there are a lot of question marks regarding the macular buckling. What about the results of peeling only the posterior hyaloid? This is the case that was operated upon in 2005, only peeling the posterior hyaloid, and this is the post-operative picture with complete retinal reattachment of the myopic foveoschisis and functional improvement. This is another case who underwent only posterior hyaloid peeling, and there is closure of the lamellar macular hole and settling of the myopic foveal schisis, improvement in the visual acuity. But let us have a look on this patient. This patient presented with lamellar macular hole complicating myopic foveal schisis, and the patient was operated upon in 2007 February by posterior hyaloid peeling only, and we could achieve successful results. But look, almost 1 year later, the patient presented with full thickness macular hole. So this technique misses one important factor. This is another patient this is a myopic macular hole complicating myopic foveal schisis that was operated upon by posterior hyaloid peeling only, and we could achieve successful results, although the macular hole persisted. But on May 2010, that is almost 2.5 years, the patient presented with recurrence of the foveal schisis and recurrence of the detachment. So what is missed is removal of the internal limiting membrane. So we decided to remove the internal limiting membrane in all cases. What is the rationale for removal of the internal limiting membrane? The internal limiting membrane is assumed to be a rigid structure in these cases, and it prevents the settling of the retina to conform to the concavity of the staphyloma. So this is how the removal of the rigid internal limiting membrane works. Let us have a look on this patient. This is the removing of the posterior hyaloid using the Tanner scraper, and removal of the adherent posterior hyaloid is followed by injection of the dye. The Tanner scraper is used to create an edge, and once an edge is created, the forceps is used to peel the internal limiting membrane. The peeling should be directed toward the macular hole, and no traction should be exerted over the macular hole. Otherwise, there is enlargement of the macular hole and creation of many breaks. The peeling should be continued till the edge of the staphyloma if you would like to remove the rigid internal limiting membrane completely and relieve the traction exerted by the structure. What about the results? This is the post-operative result with complete reattachment of the retina and sealing of the macular hole, and in this case, air was only used. This is another case of progressive myopic foveal schisis. This is in 2014 with the macula attached, and the patient has no complaint. But 6 months later, the macula became detached and the patient was complaining of distorted vision, and we decided to operate, removing the internal limiting membrane and, of course, the posterior hyaloid. And there was a peripheral break at the edge of the staphyloma. This is after the injection of brilliant peel and peeling of the internal limiting membrane cautiously. And as you see, you are working on a very thin layer of the retina. This is the inner part of the retinoschisis, and we are trying hard to exert no traction. And once you feel you cannot catch the edge, use the Tanner scraper in order to create an edge. And once there is resistance, grasp the internal limiting membrane from another location and try to move to the edge of the staphyloma. Again, this patient we succeed in removing the internal limiting membrane to the edge of the staphyloma, and the eye was filled with air. And this is the post-operative results. The detachment was completely attached, and the macular hole was completely sealed. This is another case of a recurrent macular hole that was detachment that was operated upon several times, including putting a buckle. And then we are removing the internal limiting membrane, again cautiously, because this retina was very thin and the eye was filled with silicone oil for a long time, and we all know that the internal limiting membrane is difficult to remove once the eye was filled with silicone oil for a long time. The internal limiting membrane was completely removed, and this is the post-operative picture. The retina is attached and the macular hole was closed. So these are the results of working only with removal of the internal limiting membrane. This is also a recurrent case of macular hole, retinal detachment, and the internal limiting membrane was not removed, and the posterior hyaloid was removed. And again, we tried to remove the internal limiting membrane using the same principle of always working toward the center of the macular hole and trying to detach the internal limiting membrane to the edge of the staphyloma. And this is the post-operative picture, but look here, the macular hole was not closed, so the macular hole is open. So again, something is missing. This is a case of a recurrent macular hole detachment. The posterior hyaloid was not removed in the first operation. The internal limiting membrane was also not removed. And you can see that there was a macular hole complicating myopic fovoschisis. The internal limiting membrane was removed, starting with the Tanu scraper, creating an edge, and then the internal limiting membrane was removed to the edge of the staphyloma as done before. Again, the retina was attached even after removal of the silicone oil, but the macular hole remained open. So again, something is missing. The same here, and also the macular hole remained open, although the retina is attached and the patient experienced improvement in his visual acuity. So what is missing is the inverted flap. So we changed the technique completely into the inverted flap. So in addition to relieving the traction induced by the rigid macular hole, the internal eye lamp flap stimulates proliferation of glial cells because by default, the internal limiting membrane is a basement membrane, and the glial tissue was used to fill the macular hole. And this is a case of how to do an inverted flap as described, or a modification of what described by Jersey, and they would try to peel the internal limiting membrane, always working toward the center of the macular area, and trying to take all the precautions not to reach the very edge of the macula, but you have to stop before reaching the edge of the macular area, and the internal limiting membrane is used to be accumulated over the surface of the macular hole. So the macular hole here is not put inside, the internal limiting membrane is not put inside the macular hole, but it is left over the macular hole, and the eye was filled again with air. And this is the post-operative picture. With closure of the macular hole, the visual acuity improved to 0.4, and these are remnants of the internal limiting membrane. This is again a case of central retina detachment filling the staphyloma and a large macular hole. Again, the internal limiting membrane was peeled towards the macular hole, trying to create a large flap of the macular hole. Some may trim the flap at the edge of the macular hole, creating a small flap, but I don't care of trimming the macular hole because I want to leave the internal limiting membrane over the macular hole under the air and stimulate the glial tissue proliferation in order to seal the macular hole. So as I said, you may augment the staining in order to have a better view and better result of peeling the internal limiting membrane and get it over the macular area. And this is the post-operative picture. The detachment was relieved, the hole was closed, and with improvement of the visual acuity to 0.3, and this is the picture 6 months after the operation. Again, this is a recurrent case.
1 minute, please.
I have 1 minute. Again, this is a recurrent case after a buccal and several operations. We remove first, this is not the internal limiting membrane, this is an epiretinal membrane as evidenced by the texture of the membrane, and the staining was not heterogeneous, is not homogeneous. And after creating a flap over the hole, this is the macular hole. This is after the development of detachment, and this is while the eye was still filled with silicone oil, and this is the post-operative picture. 3 months after removal of the silicone oil, the retina is attached, and the vision in this eye improved to 0.6. These are other cases with improvement in the vision to 0.4. And this is how the internal limiting membrane is left over and not inside the macular hole, and in order to help in sealing the macular hole. So in conclusion, we have multiple techniques in management of myopic traction maculopathies, but in my opinion, the best is a combination of ILM inverted flap in addition to ILM peeling reaching to the edge of the staphyloма. By this technique, you are relieving the structure over the inner side of the retina and allowing the retina to conform to the edge, to the surface of the staphylomas, and at the same time provide a flap in order to promote vigliosis in this area. Thank you for your attention.
Bismillah ar-Rahman ar-Rahim. We can start. Sorry for the delay. I would like to welcome all of you to Jeddah. It's great to have you here. Please enjoy. This is the best time to visit Jeddah. I see a lot of ladies. We have great malls, and there's a lot of discounts, so have fun. So without further ado, I will continue with what we started on, managing different problems in diabetic retinopathy. We know that diabetic retinopathy, macular edema is the most common cause of vision loss in the young age population in diabetics. For decades, laser used to be the treatment of choice. Despite good laser, 25% of patients within 3 years will progress to moderate to severe vision loss. Nowadays, we've introduced the anti-VEGF as the main treatment of choice. Steroids and laser are still used as adjuvant and more commonly as combination therapy. The idea of surgical intervention in diabetic macular edema is an option that is usually preserved for patients who do not respond to the successful conservative intervention such as laser or intravitreal therapy. In diabetic macular edema, the vitreous is firmly attached at the region of the macula with vitreomacular adhesions. This traction on the internal limiting membrane will exacerbate the progression of macular edema, and thus the separation of the vitreous or posterior hyaloid or the removal by surgery would improve macular edema. Fluorescein angiography and OCT is an integral part in the diagnosis and management of diabetic macular edema. When we tackle diabetic macular edema from a surgical point of view, we offer either parasmana vitrectomy, combining a vitrectomy with ILM peel, or adding intravitreal pharmacological therapy, or finally actually physically removing hard exudates and cysts from the macula. This is a complicated scheme, but what I'm trying to say that in 2017, we still take the patients through the regular channel of starting anti-VEGF, different trials of anti-VEGF, and then maybe changing among different types of anti-VEGF, combining laser plus or minus steroids. What we're trying to say here is vitrectomy still comes at the end. We don't have an established consensus for the treatment of these cases of persistent or tractional diabetic macular edema. So these patients, when they present, will still have to go through the usual scheme of treatment. Even though sometimes on initial presentation, you can see a taut posterior hyaloid. On OCT, you can see evidence of vitreomacular traction, be it pinpoint or broad. You would still start with the anti-VEGF. The idea of vitrectomy and DME is not new. Back in 1992, Lewis described cases of taut posterior hyaloid and ILM, that post-posterior hyaloid that he did vitrectomy for, and he showed both anatomical and functional improvement that appears to be long-lasting. We generally preserve vitrectomy and ILM peel for cases of diabetic macular edema with vitreomacular traction or patients with persistent and diffuse macular edema. To understand how vitrectomy works, we want to touch on the pathogenesis of diabetic macular edema in these tractional cases. It is multifactorial. There is initially increased permeability of the blood-retinal barrier, especially the inner blood-retinal barrier, that leads with chronic hyperglycemia leading to parasite loss and neovascular injury. with hypoxia, and the hypoxia, of course, will lead to upregulation of the vasoactive endothelial factors and other pre-angiogenic factors. We know that the posterior hyaloid in diabetic is much more adherent to the macula. The ILM is thicker with increased both anteroposterior and tangential traction on the macula. So vitrectomy actually works by mechanically relieving the mechanical force driving the progression of the diabetic macular edema. When we do ILM peel, we remove the posterior hyaloid, we remove the tangential traction and hopefully prevent its recurrence. You tend to debulk the vitreous by removing the inflammatory cytokines and the pro-angiogenic factor, and there has been some evidence of improved oxygenation and macular perfusion. The efficacy of vitrectomy in diabetic macular edema has been studied before. We spoke about the paper presented by Lewis back in '92, and by the way, this was done actually before the introduction of OCT. And there was another study that also looked at 7 vitrectomized eyes compared to control eyes, and they showed improvement both in macular thickness and visual acuity. Another study that looked at vitrectomy in diabetic macular edema with moderate vision loss, and it showed that these patients have at least 50% reduction in central macular thickness. An interesting study that compared vitrectomy to laser treatment for persistent diabetic macular edema and showed actually little evidence of difference between the two groups, with a slight significant improvement in the laser group. This was one of our patients who had persistent tractional diabetic macular edema, underwent vitrectomy. His macula got thinner, but unfortunately his vision did not improve. Combining ILM peel is an additional advantage. It will expedite the resolution of macular edema. It prevents its recurrence. It eliminates all the tractional forces on the vitreoretinal interface and by removing the scaffold used by the astrocytes to proliferate on the surface of the retina. It will also allow the macular edema to decompress and the extracellular fluids into the vitreous cavity and restoring normal retinal thickness. It is generally advisable for all diabetic patients to peel the membrane. And the big question, whether to peel or not to peel, we think with the advent of the small gauge vitrectomy, the improved visualization, the use of stains that is becoming safer and easier, and the fact that the membrane is thicker in diabetic patients, peeling of the membrane is probably more appealing. This is a quick video. I'm hoping it will work. Just showing, we routinely use triamcinolone in all our diabetic patients, both to visualize the posterior hyaloid and also to have some therapeutic effect. Once the posterior hyaloid is peeled, you can stain the ILM, and then you can try to peel. As beautifully shown by Dr. Murtada, you want to start at the periphery. It is definitely a procedure that requires expertise and experience. The efficacy of vitrectomy and ILM peel has also been studied, and there's been some prospective trial that looked at this, and they showed that in eyes that received the vitrectomy and ILM peel, there is definitely significant better improvement in the visual acuity, whereas there is another study that compared vitrectomy with ILM peel and in diabetic macular edema, of course, and vitrectomy without ILM peel, and they showed there is not a significant difference between the two groups. The use of intravitreal pharmacology is definitely an added factor. As I said, some surgeons routinely use triamcinolone in diabetic patients, but you can also use anti-VEGF. You can add laser during vitrectomy, and we believe that the use of these combined therapies will provide the clinician with a set of tools that is usually synergistic for the treatment of macular edema that is not usually available for monotherapy. The removal of hard exudates is a procedure that has been advised at a stage. We think it has a long list of complications, and we don't believe it is a safe procedure associated with complications that mandates a lot of caution. I think you want to be aware when you discuss or you decide that you want to take a patient who has diabetic vitrectomy for surgery, that the anatomical success with improvement in the central foveal thickness does not always translate to visual improvement in these patients. This is an invasive procedure with a long list of complications, and you need to be aware and discuss this with your patients. Since we're talking about diabetic vitrectomy for DME, I would like to touch on the Protocol D by the DRCR-NET. It looked at vitrectomy for diabetic macular edema, included patients with poor visual acuity associated with vitreomacular traction who failed to respond to laser treatment. 40% have gained 10 letter, and 20% have lost 10 letter with marked anatomical improvement. The study suggested that the more vitreomacular traction, the more epineal membrane, the better results you will get. I think we need to remember that this is an important empirical evidence supporting the use of vitrectomy in selected patients with diabetic macular edema. It is a non-standardized, non-randomized, uncontrolled prospective data collection. That is to say, it is a survey in which surgeons simply report their outcome. We need to remember that eyes are not equal. When we group these patients and we look at the different studies, you can see sometimes contradicting evidence, and I think this is because we did not define the patient characteristic. You need to define and determine what do you mean by traction and the presence or absence of macular ischemia, the presence of RPE atrophy, the amount of choroidal ischemia. Even the surgical parameters and the techniques should also be looked at. I think what we need is a prospective randomized clinical trial that compares vitrectomy to multiple anti-VEGF injections. You want to determine the relative efficacy, the cost effectiveness of these two procedures. But you can do vitrectomy for a patient like this with a quick improvement and both in macula and in vision, while you get other patients who have broad areas of traction, multiple cystic places that will not have the same visual results. So in conclusion, there is a definite place for vitrectomy in diabetic macular edema. The vitrectomy will definitely thin the macula. It is definitely a valid option if you want to avoid too much laser or too much anti-VEGF, and it could be cost effective when you compare doing a single procedure to a patient to multiple injections and then having to change different types of injection. I would like to stress on the point of systemic control. This is a routine for all our diabetic patients, and as long as you're treating the eye, but you also want to put some stress on the patient himself. As I said, vitrectomy is a valid option. It is very useful for patients with tractional or diabetic macular edema associated with vitreoretinal epiretinal traction, and will give very variable results in patients who are non-tractional cases. Thank you very much.